Hello, everyone. It is my pleasure to welcome you today to our September NBC Impact Series event. My name is Casey Volpe, and I am manager of NBC initiatives here at Komen. So for those of you who are new to the series, the programming for this series, these monthly webinars are envisioned as a year-long conversation where every month we present new information by topics selected by NBC patients. So today we're doing our personalized medicine talk, and this is part one of a two-part series. So if you have not yet registered for part two, please go to our landing page and go ahead and get registered so you don't miss our next speaker on this fascinating topic. Today, we are going to be hearing from Dr. Milana Dolezal and our moderator, Jennifer Williams. Dr. Dolezal is out of Stanford, and Jennifer Williams is a member of Komen's NBC Steering Committee and Living with NBC. Before we begin, I would like to thank our 2024 sponsors. So we have a special thank you to our premier sponsors, AstraZeneca, Gilead, GE Healthcare, and Merck, and our signature sponsors, Walgreens and Daiichi Sankyo. One more housekeeping note. While our speakers are talking, please feel free to post any and all of your questions into the Q&A feature in Zoom, and we will get to as many as we can within the hour. But please remember that our speakers are not able to provide individual medical advice, okay? They're only here speaking to their expertise and experiences, and they're not able to offer specific second opinions here today. So towards the end of our programming, we're going to drop a survey link. Your feedback's really important, so keep a lookout for that. Now we're going to dive in, and I'm really excited that you're all joining us today. I would like to start by introducing our moderator, Jennifer Williams. Jennifer Williams had early stage breast cancer not once, but twice before it recurred later as metastatic breast cancer in 2022. Since her original diagnosis, she's participated in numerous fundraising and breast cancer advocacy events, including Komen public policy initiatives, both on the state and national level. In 2023, she coordinated an informal educational workshop with University of Maryland Comprehensive Cancer Center and her church parish at St. Bernardine's Catholic Church in Baltimore. She's originally from Opelousas, Louisiana, but has lived in Baltimore County, Maryland for over 25 years. She is a 25-year-old son who she's extremely proud of, and in her spare time enjoys hiking, water fitness, and reading. Jennifer, the floor is yours.
Hello, everyone. I want to introduce Dr. Milana Dolezal. Dr. Dolezal is a board-certified hematologist oncologist with Stanford Medicine Center, Cancer Center in Emeryville, and a clinical associate professor in the Stanford School of Medicine Division of Oncology. She strives to work with patients to develop care plans that are comprehensive and personalized to achieve the best possible outcomes and quality of life. Dr. Dolezal has extensive experience in research and drug development. She previously held positions as a clinical scientist, assistant medical director, and associate medical director in the bio-oncology therapeutics units of the biotechnology company Genentech. She has conducted clinical research with fertility preservation in patients with breast cancer, advanced treatment for triple-negative breast cancer, and patients' adherence to anti-cancer therapy. She has co-authored articles on her research findings that appeared in the Journal of Clinical Oncology, Cancer, and other peer-reviewed publications. She also co-authored the chapter, Progression from Hormone-Dependent to Hormone-Independent Breast Cancer, in the textbook Hormones, Genes, and Cancer, published by Oxford University Press. Dr. Dolezal has made presentations to her peers at meetings of the American Association of Cancer Research, the American Society of Clinical Oncology, and the European Cancer Association. Welcome.
Well, thank you so much. Let me go ahead and share my screen here. Make sure I've got this all up. Okay, I think you guys can see this okay. Well, thank you again. I really appreciate that you've invited me to speak today. As was mentioned, I'm an associate professor at Stanford. I subspecialize as a passion of mine in terms of breast cancer treatment and management, but I'm also a hematologist, so I wear that hat, and you'll see a little flavor of that in this talk today. And today I'm going to be talking about genetics and genomics and precision medicine and personalization of how we translate some of the molecular diagnostics to cancer medications. And I have to say, it's one of the most exciting times that I've experienced in my career in terms of new options for our cancer patients. And I'm really going to hone in on just the last 2 or 3 years and all of the new advances during that time period, sort of since the beginning of the pandemic. So thank you for joining me. See if I can advance my slide here. There we go. So I hope to touch upon all these different questions here, which are probably burning in your mind around how do you explain personalized medicine? What's the difference between genetics versus genomics in the tumor DNA? You'll see this little NGS a lot. This is sort of like your Where's Waldo on the slide. So I encourage you to hone in on that NGS. And NGS stands for next gene sequencing or next generation sequencing, actually looking for tumor mutations. So that could either be on solid tissue or in the blood. So if there's a take home that you remember from this talk, NGS. How do you apply personalized medicine? What goes into a decision? Really the difference between prognostic and predictive markers, and understanding that breast cancer is just not one tumor type. There's multiple types of breast cancer and even heterogeneity within one patient. You can have a primary breast mass, maybe that's HER2 positive, but a metastases to liver that becomes HER2 negative. And that liver lesion might not respond as well. So keeping all of that in mind, how do you choose a particular therapy, what to ask the doctor, targeting the outside of the cancer cells versus the inside? I'll talk through that. And then how do you monitor? We have different types of surveillance techniques that are incredibly sensitive for even picking up minute amounts of a patient's cancer DNA in their bloodstream. And what I'm really even more excited about is what's on the horizon. What's the future look like in terms of further personalization of cancer care? So we're living in a biologic century. It's this idea of bench to bedside. So laboratory bench, really dissecting and understanding those cancer signaling pathways and bringing it to a patient's bedside or infusion chair or recliner chair at home if it's a pill you're taking, and really honing in on the underlying tumor biology. So important distinction here is the difference between genetics versus genomics. So I think they're used incorrectly interchangeably at times. So genetics really refers to family history, something called germline. So when there's a test that's done, either saliva or blood, that's looking for inherited gene mutations, either from mom or for dad. Unfortunately, it can also be passed on to children. And that most commonly is known, the most common ones that we know about are BRCA1 and 2. There are a lot of other ones now, PALB2, CHEK2, etc. But why I bring this up is this actually translates into a medication now that we've had in the metastatic setting, and most recently in 2022 in the early breast cancer setting, targeting that BRCA pathway. We also have immunotherapy, a little more common in colorectal and different GI malignancies and endometrial with a different cancer syndrome called Lynch syndrome. However, we do use immunotherapy in, for instance, triple negative breast cancers, especially that have a high MSI kind of tumor burden. Now that is different than genomic testing, which is somatic testing, which is actually looking at the cancer genes themselves, the tumor biology, the mutations. And this is how we can actually target how the cancer grows and signals. And there's your Where's Waldo NGS on the slide. So we're really transitioning from sort of this traditional medicine where it's kind of the trifecta of chemotherapy, radiation, and surgery, where all of this is somewhat tumor agnostic in that chemotherapy kills all fast-growing cells. That's why people can lose their hair, etc. So it's really not personalized or precise, as opposed to precision medicine, which is some of what I just alluded to. So looking at the genetics, not only family history, but also the genomics and what the tumor is using to grow, and immunotherapy. So it's really targeting specifically cancer cells. So all of these genetic and genomic testings are now guiding treatment recommendations. So molecular profiling, I mentioned NGS, prognostic markers that I'll talk more about, predictive of adverse events. This is definitely an area that I think we need to get better at, understanding who's going to experience side effects from different drugs. And then what about different predictive markers of drug sensitivity or resistance? So to dive a little bit more into the genetic germline from your parents, historically it's been used for screening recommendations, risk reduction surgery, so that could be bilateral oophorectomies, bilateral mastectomies in terms of prevention, family planning, etc. And just to point out here, I think this is important to get out into the community, that really only about 10% of breast cancers are hereditary. And BRCA1 and 2 are responsible for about half of those. Enriched in certain populations, Ashkenazi Jewish, Sephardic Jewish, etc. But I think that a lot of people want to understand, well, how did I get this? I eat really well. I don't smoke cigarettes. I barely drink. In terms of environmental stuff, but also in terms of the genetics, very smaller percentage of our patients have that. But we still need to test because there's very important treatment implications. In terms of the general population, about 12% of women can get breast cancer, about 1 in 8. But in terms of BRCA mutations, you can see much higher levels of both breast and ovarian cancer. I applaud Angela Jolie. I think she normalized the conversation about knowing your genes. And I really like this quote from this opinion piece. Life comes with many challenges. The ones that should not scare us are the ones that we should take control of. So thank you for bringing this to light and has really normalized these conversations, I said. So who should receive genetic testing? I bring this up because this was recently updated based on our American Society of Clinical Oncology and SSO guidelines in terms of a 2024 update. Anyone diagnosed with a breast cancer at 65 years old or less should have genetic testing. For greater than that, there's certain treatment indications. This is juxtaposed by our NCCN panel testing, which is the National Comprehensive Cancer Guidelines. With all that being said, back in 2019, the American College of Breast Surgeons came up with a position consensus statement saying that any breast cancer should be tested. So keep that in mind in your conversations. How do we test? Either blood or saliva. We really moved away from single gene testing, just checking BRCA1 or 2, and have really transitioned to more of the multi-gene panels, Ambry, Invitae, ColorMe, still Myriad as well. What are the types of results? So either negative, a variant of unsignificance. That means in the whole gene of, let's say, BRCA1, there's basically just maybe 2 or 3 pathogenic, meaning cancer-causing mutations, but you can have other mutations on this big train with multiple cars. So something in the caboose might not be cancer-causing. Positive, obviously, we've talked through that around procedures and treatment implications. So what sorts of treatments? So this is a trial, the Olympia trial. I'm not going to get into all the details here. This is sort of a doctor part of it. Just pay attention to what I'm saying. But this actually looked at in a curative breast cancer population, either triple negative, mostly with a BRCA1 mutation, or BRCA2, that was usually hormone receptor ER positive, doing all the chemotherapy, surgery, radiation, and then after all that, taking an additional 1 year of this PARP inhibitor pill called olaparib, also known as Lynparza. And the endpoint was invasive disease-free survival. What's really even more important here, that over time, one of the secondary endpoints was overall survival. And you can see here that in this curative population, that's why these survival numbers are so high up here in the 90s, etc. There was, just with a couple year follow-up, a 3.4% benefit. And I expect over time, especially in these younger women, these curves here will continue to separate and have maybe even a double-digit type of overall follow-up many years later in terms of overall survival. So during this pandemic, in March of 2022, the FDA approved olaparib olaparib in the early breast cancer setting, following suit after a 2018 approval for stage 4 metastatic cancer. This is a study that was recently presented in June at our American Oncology meeting. And this was interesting because it was looking not at only metastatic breast cancer with these germline mom and dad mutations, including what I call BRCA3 or PALB2, but also somatic mutations in the tumors themselves. So didn't get the gene from mom or dad, but somehow the tumor has now used this pathway to manipulate and grow. And that's the somatic genomic. There's your Where's Waldo NGS. So this is an interesting trial to look at. I'm not going to go into all the details, but BABE is basically the take home here for me. Small numbers of patients, keeping that in mind. There was a response rate in patients whose tumors expressed BRCA1 and 2 to about 37%. So this is hypothesis generating and thought provoking. This is a busy slide, but what I want to point out here is really that there's so much heterogeneity in breast cancer that also impacts how we treat different types of breast cancer. So some of the molecular differences are here from well over 2 decades ago, which is hard to imagine. It's been my career so far. And these luminal A versus luminal Bs and how we really fine-tune different subtypes of breast cancer, prognostic versus predictive differences. You're probably familiar with either Oncotype or Mammaprint that's used in the early breast cancer setting to dictate whether or not we use chemotherapy. Will there be chemotherapy benefit? BCI looks at more than 5 years of an aromatase inhibitor, tamoxifen, in terms of an anti-estrogen strategy. And then here's your NGS again in terms of all the different mutations. Now that little box up there in the upper left actually has at least 20 something mutations. There's no names on here, but this is actually from an actual patient of mine who was diagnosed with breast cancer back in the 90s, was diagnosed with a metastatic breast cancer well over 20 years ago, is still alive and living, well, on therapy and with chronic disease of metastatic breast cancer. But you can see that there's a lot of little dots there in terms of all the mutations that have been acquired over this 2 decades, essentially. So I like to quote George Sledge, who's a well-known mentor in the breast cancer community, around all the different subtypes of breast cancer and how we really sort of think of them as a band of criminals. So you treat them differently based on how severe the crime was. So if you have sort of a low risk estrogen positive breast cancer, maybe they're just on an aromatase inhibitor, and that's more like the misdemeanor. But if you have a triple negative breast cancer, has committed a lot of crimes, they might be felonies, and you're going to punish that breast cancer accordingly. So to continue that jail analogy, here's the Alcatraz here in San Francisco in my backyard. I've done this escape from Alcatraz triathlon a couple different times. That might be one of my heads there. But this is showing you that these prisoners basically can escape. And now these are akin to an analogy of circulating tumor cells. And we can actually pick up these cells with high sensitivity now, circulating in patients' bloodstreams, even several months or even a year plus prior to a breast cancer progression or other type of progression. I'll talk more about that technology. This is work done by Professor Christina Curtis at Stanford, even showing that within an estrogen positive, HER2 negative type of breast cancers, there's even more aggressive types of subtypes, these IC1, 2, 6, and 9, that have worse outcomes, even worse than triple negative breast cancer. They have endocrine therapy resistance. So how can we use targeted therapies to overcome this endocrine resistance? I think it's important to understand the difference between predictive and prognostic. Prognostic is how will this cancer do? Is this a bad one? Does it have a chance of coming back? Versus predictive, which means can predict for a specific intervention or medication. So for example, HER2 is both prognostic. pretty aggressive grade 3, high grade type of breast cancer, not as well treated prior to the advent of HER2 targeting agents used with chemotherapy. And that's the predictive part. Using HER2 agents is predictive. And then I mentioned Oncotype DX, BCI. So these are other predictive tests. I think it's also important to set the stage to understand how do we use these targeted therapies and how do they work? So either you're targeting the outside of the cancer cell. So cancer cells have different little hats or receptors that they wear. So that could be estrogen, progesterone, HER2. And so these are extracellular receptors versus all the signaling pathways on the inside. So when I talk about antibody therapies, antibody drug conjugates, so antibodies to a certain target like HER2 linked with chemo or even bispecific antibodies, they're all targeting the outside of the cell, the little hats that the cancer cells are wearing. They're intravenous. They have a long half-life, so they're dosed generally every 3 weeks, etc. They might not get up into the brain because they're big, large molecules, and they have specific receptors. They don't have a lot of drug-drug interactions, different than pills, small molecule inhibitors that really work on the inside of the cell. They're short half-life, so they're usually dosed once a day, twice a day. Since they're small, they can get up into the brain. But in that, they can actually hit different pathways, so there can be more toxicity, diarrhea, rash, if it's hitting an EGFR pathway, for example, and they do risk some drug-drug interactions with other medications that you could be taking by mouth. So we have a hard job. So give your oncologist a break, because these days it's really hard to be a jack of all trades and a master of none. So in 2023, the FDA featured 45 oncology drug approvals, including 12 new types of drug to the market. And just in December, as of the end of last year, there were 11 bispecific antibody approvals. So the point here is get second opinions. Really, it's shared decision-making, patient-centered care, and participating on clinical trials. So here's a nice schema to just show you, just during this pandemic, how many FDA-approved agents there were for HER2-positive breast cancer. You can see the outside of the cell here. I'll talk a little bit about trastuzumab deruxtecan, also known as Enhertu. That is an antibody drug conjugate targeting HER2 here. Then we have pertuzumab, trastuzumab, and then here's your inside of the cell. So in the HER2 space, we have tucatinib, does get up into the brain to help prevent and cure HER2 positive breast cancer gone to the brain, or at least control it, and other tyrosine kinase small molecule inhibitors. So I can't give a 3-year revolutionary talk without mentioning trastuzumab deruxtecan, also known as HER2. This is an antibody drug conjugate. Your backbone there, the V is trastuzumab Herceptin, linked to 8 little balls of chemo. It binds to the outside extracellular part of the cancer cell. There can be variable level of HER2 expression. So there's also something known as HER2 low, just a little bit of HER2 expression. Then that chemotherapy actually directly gets delivered inside of the cancer cell. So you don't get all of those other side effects as much as you do with chemotherapy alone. So targeted therapy, it can also go to neighboring cancer cells. So this was an amazing presentation at our oncology meeting in Chicago 2 years ago now. Standing ovation, 30-some thousand people standing up and clapping when they saw this data. This is looking specifically at hormone-positive breast cancer. Patients who have stage 4 cancer that have cycled through many types of hormonal anti-estrogen manipulations, even 1 line of chemotherapy, and then they either got this antibody linked to chemo versus chemo. And this was why everybody stood up and clapped, because in this highly pre-treated population with at least 4 lines of prior therapy in the stage 4 setting, I'll explain what lines mean, there was a doubling of what's called progression-free survival and also an overall survival improvement. So this made lots of New York Times articles and really remarkable data that's changed how we treat metastatic breast cancers. ADCs have really transformed that. So I'd like to shift gears a little bit to think about this in a different way in terms of how does cancer grow? So I don't know if we have any New Yorkers in the audience, but this is basically how can you get from Grand Central to the Met? So there's different ways. So you can go above ground. So if you think above ground, that's sort of the outside, the extracellular part. So you could take Fifth Avenue, walk by the park, you could take Park Avenue. Well, let's say we use an antibody to block one of those, meaning we shut down Park Avenue. Well, you can still get there above ground. Well, let's say we shut all of those outside of the cell kind of pathways down. Well, guess what? Cancer gets super sneaky. It makes different mutations and now goes underground and now uses those pathways. So you could take the green Lexington line here. So this is what cancer does. It's very sneaky and figures out how to create detours around different roadblocks. So one of these pathways is known as the PI3 kinase mTOR pathway. About 40% of breast cancers express this. It is a known mechanism for resistance specifically to either HER2-targeted agents like trastuzumab, pertuzumab, Herceptin, Perjeta, et cetera, or hormonal therapies, anti-estrogen therapies. Good news is we have drugs now that can actually specifically go into this inside of the cancer cell, the PI3K, AKT, mTOR pathway, and turn it off. So it's not constantly on. When it's on, the cancer cells are dividing, they're mutating, they're making babies, they're growing, they're spreading. We can actually pick up these mutations now in the bloodstream with this liquid biopsy idea. And there's your NGS again, next generation sequencing. The other thing that's nice about liquid biopsies as opposed to solid tumor biopsies is it encompasses all the different cancer sites. So if a patient has a breast mass, maybe 2 or 3 liver masses, maybe bone metastases, all of that heterogeneity is captured in one liquid biopsy. So why does this matter? Well, as I mentioned, we have drugs for this. On the lower left, you can see all the different sort of targeted mutations we have in breast cancer, and the list keeps growing. We just added ESR1 to that. And these mutations can be picked up in liquid biopsies. You can see here, these are NCCN guidelines. I'll talk about capivasertib, which is the second one down, and elacestrant, which are actually targeted therapies against breast cancer mutations. In terms of lines of therapy, I alluded to this. So the first line of therapy is what you get at a stage 4 metastatic diagnosis. So this could either be de novo, or this could have been somebody had early breast cancer and then unfortunately it came back many years later. In this first line setting, hopefully we get years plural of sort of a therapy lifespan. But then, unfortunately, there's either a toxicity or the disease more commonly progresses. Then you go to second line. And at each one of those lines of therapy, next generation sequencing should be done to look for mutations that we can really do targeted therapy for. So there's your NGS. Also, I think what is important to take home from this schema is that each line of therapy starts to get shorter and shorter in terms of how effective it is. So this was a really exciting study. Again, pay attention to me, not necessarily the slide. This was presented at our San Antonio Breast Cancer Conference in December. I was there, and it was a really interesting setup because this was not on the agenda, and it was presented to the leaders of the meeting on a Thursday. And it was so remarkable that they actually added it last minute, 11th hour, onto the Friday agenda. So this was the INAVO study. This was a first-line study, very high-risk patients that had this PI3 kinase mutation. Most of those patients had it picked up in the blood. They had a hormone-positive, HER2-negative early breast cancer that then unfortunately progressed. So now this is the first line of therapy at that progression. It was either a triplet or a doublet. So with a CDK inhibitor like palbociclib, Ibrance, a shot, fulvestrant, and a third agent, this new agent, And again, this was really impressive data with a doubling of progression-free survival. The median follow-up is less than 2 years here. So I expect over time, these curves will continue to separate, and the response rates were doubled in this high-risk breast cancer population. This is kind of busy, but it just shows you how we're really refining our endocrine sensitivity. And in that population I just showed, they're just endocrine resistant, unfortunately. If they develop resistance mutations either at the beginning or soon into their course of therapy. Here's another PI3 kinase type of inhibitor. It hits AKT in particular, so a little downstream when I showed you the inside of the cell. This is called capivasertib or Truqap. This is now FDA approved as of last year. And here's the data here in terms of also a doubling of improvement in progression-free survival. There's another agent I wanted to touch upon. There's different types of ways we can target the estrogen receptor. This is exciting because this is the first approval I've seen in over a decade in the estrogen positive space. Faslodex is a SERD that chews up the estrogen receptor, but it's given by a shot. It's not the most comfortable. We're not sure about its bioavailability. So these are actually oral pills. Don't have to come in for a shot. The one approved to date is called elacestrant, and this actually targets a different mutation called ESR1. The cancer's basically made a mutation in the estrogen receptor, so it doesn't need to eat estrogen as food. So aromatase inhibitors or tamoxifen that block that production of estrogen don't really work anymore, and this receptor is just constantly turned on. So these drugs actually bind to that receptor as opposed to stopping the food, which is the estrogen. These mutations can develop over time in the sense that at diagnosis, only about 5% of breast cancer patients have an ESR mutation. But once you have had multiple lines of therapy, specifically several years of an aromatase inhibitor, these mutations develop over time. So that's why I said NGS at each progression in the metastatic setting, because by the second or third line, there'll probably be an ESR1 mutation, and we have pills for that. This was the EMERALD study that looked at that. Again, don't pay attention to the slide, pay attention to me. These were patients who had all had a prior first-line CDK inhibitor like Ibrance, Palbo, etc. And then they had progressed on that, so it was largely second or later line of therapy. They might have had a line of chemotherapy as well. And this also showed improvement. Busy slide as well, but the point here is that the patients who had elacestrant, who had at least a year or longer, year and a half, of a CDK inhibitor with an anti-hormonal strategy really did best with this. And that speaks to this is a more hormone sensitive still type of patient population with breast cancer. And these are the numbers here. And this was approved in January of last year. Everything's a balance in terms of side effects, risks, and benefits. So these are things to consider. So here's just a summary of all those medications I just mentioned. Again, elacestrant, capivasertib. We also talked about germline, olaparib, and other PARP inhibitors, talazoparib, and then for MSI high tumors, Pembro. So how do we put all this together? This has gotten so much more complicated these years. You need roadmaps over the last 3 or 4 years to figure out how to treat breast cancer. And in particular, this is hormone receptor positive breast cancer. But good news that we have many more options and patients are living a lot longer because we have additional third, fourth line therapies. So I talked about PI3 kinase, I talked about BRCA, I talked about ESR1, I talked about TDXD in HER2 low, didn't talk about sacituzumab, another ADC. So switching gears in the last few minutes here in terms of how do we follow, typically it's been kind of older school tumor markers in the stage 4 setting, CT scans, imaging. I mentioned a lot about NGS. This is the different mutation testing. but it's just looking for any circulating tumor DNA. It's not so specific to a patient's cancer per se. We have more tumor-informed minimal residual disease assays. So taking a page out of the hematology books, where blood cancers, we were able to pick up different types of leukemia cells in the bloodstream, even after we think a patient's cured, possibly with bone marrow transplant, et cetera. So this is actually looking at a patient's tumor. We sequence the tumor with whole genomes or whole exon sequencing, find a unique 6 code, and then we're able to make primers against that piece of tumor DNA, amplify it up by something called polymerase chain reaction to about 100-fold. So it's very specific to that tumor, and you can find very minute quantities of tumor DNA in the bloodstream. This is just a schema showing a patient who underwent what we hoped would be curative therapy. They had a cure. They're still cured several years later, but now all of a sudden we're starting to pick up some of that minimal residual disease. Then eventually they relapse. So it's a harbinger. It's a bit of a canary in the coal mine to say that the breast cancer might come back, and that might be, even in a curative setting, an indication to do CT scans or PET CT scans and find the disease a different way. I think the big question is, well, if we find it, what do we do about it? What are we treating if we can't really see it yet? And here you can see it's a predictive biomarker in multiple tumor types, also studied in colorectal cancer. Here's just an example that if patients do have circulating tumor DNA, unfortunately, they just don't do as well. And that's what the blue line is. Whereas patients don't have circulating tumor DNA, their relapse-free survival is very, very good. And that's that yellow line, and overall survival as well. So there's a lot of clinical implications here. We're also using it in immunotherapy now to assess treatment effectiveness. So the last thing I wanted to touch upon is really the future. So going back to the past, before we talk about the future, Avastin is a blood vessel choker. Tumors can do what's called neoangiogenesis, where they grow new vessels to themselves to bring themselves oxygen, sugar, etc. And so Avastin was a medication that's been around for a long time for many tumor types. But in terms of breast cancer, it was taken off the market in 2011, mostly around this overall survival endpoint. It was an FDA meeting, something called an ODAC. But the good news is sort of we've repurposed some of that. And this is just presented literally less than a week ago at the ESMO European Oncology meeting. This was an earlier phase study out of China, but it's looking at metastatic triple-negative breast cancer with Abraxane or nab-paclitaxel combined with what's called a BiTE antibody, a bispecific antibody that has 2 heads. So think of like a hydra. So, one of the heads is attacking sort of VEGF, and the other one is actually immunotherapy. Again, busy slide here. There were not a lot of patients here, but you can see that, brain metastases were not included, small amount of metastatic sites and liver metastases. So really a first-line triple-negative population. Bottom line here is, even though the numbers are small, if you look at the patients who had PD-L1 positive, so immunotherapy kind of positive disease, in terms of stage 4 triple-negative breast cancer, the approvals for immunotherapy like Keytruda, et cetera, are for patients that have a high what's called CPS score or PD-L1 positivity. Here, all of those patients responded, but even patients that were PD-L1 negative still responded to this. So stay tuned for that. This is another super exciting thing I was involved in when I was in San Francisco at CPMC. This is this idea of an avatar, a mini-me. So this project that Dr. Mo Kashani, kudos to Mo, and he gave me this slide, looks at a patient's tumors. So you take a biopsy, fresh biopsy, and then it's made into a cancer cell line, so individual patient cancer cell line, and then 2 different pathways. One is those cells are put into 1,000 different wells, teeny tiny wells, and they're treated with multiple different drugs, what's called high throughput screening, to see how well one drug over another might kill those cancer cells. And then we might actually try that particular therapy in a patient. The second part is taking those cells to make a tumor on a mouse. And then you can follow the mouse, you can treat the mouse with a medication to see if the tumor shrinks before actually treating the patient. So this is really cool technology. Gene editing, I'm going to put my hematology hat on here for a little bit, and kudos to Jennifer, right in my backyard here at University of California, Berkeley. She got a Nobel Prize for this CRISPR technology. We now can edit out certain genes. And so sickle cell disease is a really interesting evolutionary concept. So you have red blood cells that are like nice round donuts. But guess what? Malaria in Africa predominantly likes to get in there, can destroy those red cells. So the body over many, many thousands of years then basically made those cells sickled like a sickle. So kind of a little U, and now the malaria can't get in. But there's a lot of implications for that in terms of sickle crises, inadequate oxygen, etc. So now we have a one-time infusion, one sit down, where we can essentially really cure those patients. Similarly with hemophilia A, it's a bleeding disorder where catastrophic bleeding events can happen in joints, spontaneous bleeding, even brain bleeding. And now there's a therapy where just one dose, we can really essentially cure those patients. So wouldn't it be nice if we could just sort of edit out BRCA or some of these other hereditary mutations so patients don't have to have bilateral mastectomies or have their ovaries taken out? That's the future that I would like to see. Similarly, there was just last month a T-cell receptor gene therapy for a type of bone synovial sarcoma, single infusion. Finally, I'd like to end on mRNA personal vaccines. So like the COVID vaccine, we've become familiar with that mRNA technology. But this was a wonderful study that was also just presented 2 months ago by Jeff Weber. Unfortunately, we lost Dr. Weber just last month to pancreatic cancer, who's a real hero in the oncology field, especially in melanoma. But this, he was able to present this, which is great. So this is a personalized cancer vaccine in combination with immunotherapy for melanoma, skin cancer. I'm not going to go into the details of the technology here, but basically making a specific melanoma vaccine for patients using their own cancer melanoma cells. Pretty remarkable results, almost a 50% reduction in risk of recurrence and death. Encouraging trend, this is still early data in overall survival. So this is sort of how I see the future in terms of editing out genes, working on personal cancer vaccines, etc. So how can you help? So there's the Komen Share for Cures, which really connects researchers with information. And your information is unique, and you can help us learn more. I think we have a lot of people all over the world who are working sort of independently in their silos, making great strides, getting Nobel Prizes. But how great would it be if we could just advance and speed up that process? If everybody kind of got together in a institution agnostic sort of way where we could figure things out faster to help patients. Here's how you can do it. So thank you so much for your time today. I think the take homes for you are NGS, next generation sequencing, really understanding that we live in a genomic era. We have a lot of newer diagnostic technology. We have targeted molecular therapies for precision medicine and personalized cancer care. Remembering the heterogeneity of breast cancer. And let me finish by saying my humanity is bound up in yours, for we can only be human together. Thank you so much for your time. All right, I'm going to stop the share now. Okay. So I know we started a little late. I think we still have at least 15 minutes for questions.
Yes, and we have a few questions, if that's okay. We have a few
Sure,
questions for you. Okay, just give me one moment. Sorry about that.
no
A
worries.
little technical difficulties here. Well, the first question, a lot of patients are not sure the right words to ask their doctors. Do you have any suggestions on what the proper words that have to be used?
Yeah, so, I was trying to put things out there in a way where I said, listen to what I'm saying, not necessarily at the slides. So there are a lot of patient-friendly resources out there. I mentioned the NCCN, which is the National Comprehensive Cancer Network Guidelines. There are patient versions, so you can sign up for that with your email and a password. It's free. I'm also working with a startup company started by a breast cancer survivor who really felt like she needed a dictionary and a roadmap to understand all this. It's called Manta Cares. And so it's a tool we're developing that's as an app, which can really kind of help you understand not only side effects of therapies, toxicities, but also questions to ask your doctor. So I would say, start with maybe the patient NCCN guidelines around kind of questions to ask. Um, Hopefully that's helpful. And then look out for Mantis Care because I think that'll MANTA then care help with that. And I think the other piece is just be proactive. I always tell my patients, like, stop me if I'm not making sense and talking at you or over you. My goal is to have a shared care model and not to talk at patients. I'm giving you a lecture today where I'm sort of the talking head, but at the same time, the point is to really come to conclusions together about what the best next steps are.
Right. Okay. Now, could you tell me more about immunotherapy? Just a little bit more details with that?
Sure. I mean, that I gave another talk in Seattle a couple months ago where I talked more about immunotherapy, which is a little more for the triple negative breast cancer patient population. So the way I like to explain immunotherapy to patients is your immune system does a really good job of getting rid of bacteria and viruses, and it does that a couple different ways. So it's sort of the T cells are surveilling and the B cells make antibodies. So what does cancer do? So cancer's super sneaky. So when you're inside your mom's uterus, basically your body marks itself as self. So if you can imagine, all of your cells on the inside of you are yellow. Now cancer comes in or develops and it's like, everybody here's yellow. I'm going to put on a yellow raincoat and I'm going to put on a yellow hat, like little Paddington, and I'm going to evade. I'm going to sneak around. It's the cloak of invisibility that Harry Potter has to basically evade the immune surveillance. So that's one mechanism that cancer can do that. The other mechanism is that you can kind of turbocharge your immune system in times of an invasion, so you have the fever, cytokines are released, and those basically raise the body temperature to kill bacteria. So what does immunotherapy do? It does a few things. One is it turbocharges the body's immune system to basically have those T cells constantly out there. So they're always looking around, surveilling. So the other analogy I use is like not redshirting, a football player or something. They're always out there on the field. They're always playing. They're always looking around. So immunotherapy can do that. The other thing it can do in terms of something called PD-L1 ligand is that's that yellow cloak that the cancer is wearing. So these immunotherapy IVs actually take that cloak off, and all of a sudden the body's like, hey, you're purple, you don't belong here. And then they go and they destroy. So it really manipulates your body's own immune system to turbocharge it to fight the cancer.
Okay. Now, the final question I have is two-part. Are targeted therapies the same as personalized or precision medicine? And does personalized medicine benefit everyone? are there are MBC patients? Are there MBC patients who do not benefit from a targeted approach?
Yeah. So precision medicine and personalized medicine are sort of used interchangeably. So if you can think about precision medicine, about almost everything I talked about today. So these targeted agents, these molecular types of pills that we use. So that's precision medicine. Now, the personalization of that is then how do you apply this technology or these drugs and translate it to a particular patient therapy. So if the patient has a PI3 kinase mutation on the inside of the cell, the personalization part is we actually give them a medication that fights their particular cancer. So that's the explanation that I would give. In terms of the targeted approach, so here's the thing, if you don't have any of these mutations picked up in the bloodstream or on a tissue biopsy, if there's no ESR1 mutation, if there's no PI3 kinase mutation that the cancer is using, well, then you can't get this targeted approach. Now, there are other targeted approaches. I mentioned HER2, so that would now almost apply to everybody because we have a new ultra low HER2 approval coming soon per another trial that was just presented at an oncology meeting. So I think any HER2 positive breast cancer patient, even if it's 0.5, can get a drug like TDXD, which is somewhat targeted. There are other agents like sacituzumab that doesn't require a particular target. So I think in general, all metastatic patients will benefit from some of these targeted approaches. The personalized part comes in with which ones and in what sequence.
Okay, thank you. Thank you.
Did that make sense, Jennifer?
No, it did. And because I'm metastatic, and that's something that I was particularly concerned about. So it definitely answered my question. Thank you.
Awesome. Well, everyone, that's all the questions we had come in today. So firstly, I want to thank our fabulous speaker, Dr. Dolezal. You really made what is a very complex topic, and you covered a great deal of information. You made it really digestible, which I always appreciate. So thank you so much for your time. Jennifer, thank you for moderating. I'm so sorry your camera gave up on you. It is a live event, so c'est la vie, these things happen, but you did a fabulous job, and I was grateful to have you here today. To our attendees, our session was recorded and it's going to be posted to our landing page and delivered to your inbox soon. So you can rewatch. You can also visit our landing page, komen.org/MBC series, to check out other sessions. Because like I said, different topics every month. So pick and choose which ones are of most value to you on your journey. Please help us spread the word about this content with your friends, your family, healthcare professional, anyone you think that could benefit. So once again, I just want to take a quick moment and acknowledge our sponsors for the MBC Impact series. So thank you to GE Healthcare, AstraZeneca, Merck, and Gilead, and then to Walgreens and Daiichi Sankyo as well. Last but
Don't forget about Share for Cures.
Yeah, please do not forget about Share for Cures. There was a QR code up, but a quick Google of Share for Cures in Komen will bring you to the landing page as well. Check that out, sign up. It really is an incredible cause and a nice way to get involved, since you can kind of take control of that just in case there's maybe not access to a clinical trial or you aren't eligible for ones that you have locally. So lastly, but certainly not least, the next event will be on September 30th, and is our part 2. We will hear from Dr. Gordon Mills about some current research, even more current research, because Dr. Dolezal covered quite a bit today as well, and some specific research he's conducting at the Knight Cancer Institute. So that link is live to register for. So again, please go check it out, and I will send that link to all of our registrants via email once we get the video uploaded as well. There is a survey link in the chat now. Oops, except I put it in the wrong place. So let me fix that. Again, live event, and it's Friday. So here we are, guys. All right, so that's there now too. Please take a moment and fill that out. I personally get those results. I help pick the topics and develop the series. So I want to make sure we're putting out information that's really useful. So it's not going into the internet abyss, I promise. So just take a second, give us whatever feedback you can. Thank you for everyone for joining today. Thank you for everyone for supporting the event. Stay safe and stay connected. Have a great weekend.
Thanks again. Take care.